So we go on in the program, and we are still active with embolization treatment. And the next will be now, I see he is already jumping to the podium, yes. So we will hear now something about the sympathetic denervation of the liver.
Hello, everybody. Thank you for the invitation. Kind invitation. Okay.
Not here. No, no.
I think mine is now.
Yes, yes, go on.
Okay.
Epistaxis, I like that. Not epistaxis, but it's treatment.
Okay, thanks again. I was invited here today to share our experience with epistaxis and how we deal with this kind of pathology. Very briefly, everybody is familiar with the epistaxis. About 60% of the undoubted population can be refractory, can be unusual, can be without any heterogeneous trauma. So the natural history is very different and widely, but when it's occur, it depends how we are going to deal with it. Like I mentioned, there is a lot of etiology of epistaxis. The most common of them are weakness of the thinner artery walls inside the nose, caused by different syndromes, caused by complication of a tumor, could be involved with trauma or iatrogenic one. So what happens when we have to deal with the epistaxis, which is not caused by malignant process or iatrogenic trauma? Then it depends of how active and non-active is the bleeding, how severe is the amount of bleeding coming out of the nose, and how long, how prolonged is the bleeding itself. So considering these factors, we can do simple nasal compression. Every of the patient which has such kind of small severe epistaxis can do it at home. If it's continuously go above 30 minutes, then we can seek some assistance of the physician, in which they can see directly microscopically what could be the reason inside the nasal cavity. So if there is nothing there, we can go for a simple topic agent for coagulation on the surface level of the nasal cavity. If there is non-stopping, then the physicians can perform so-called nasal packing. It could be anterior or posterior, depends on the region of the bleeding, and leave it like this for the hemostatic process could be done in time. Again, if this doesn't stop, then we go for additional imaging modalities like CT with contrast or direct DSA examination, so we can search for the reason of the bleeding. The embolization is described long ago. It's nothing new. Starts from even first literature reports in 1974, using different agents, starting with geospon and small particles, which can cause this thromboembolic process, which can stop the bleeding itself. Embolization at that time starting to develop and showed very high success rate with low complication rate. Mainly minor transition complication you can observe, but the major complication is less than 2 to 4% reported in the literature. So what we should know about the epistaxis, of course, the anatomy. We should well recognize and know the anatomy so we can search for the reasons of the bleeding. It's not so complicated, and if you have a good imaging modality before that, CT or MRI, you can search easily for the reason. Mostly the technique involves like a normal diagnostic procedure with 5 or 6 French, mainly femoral approach. Of course, if the patient has some individual preference should be past the femoral, then you can switch to radial. Then, of course, selective catheterization of the both external arteries, common and both external too, to see where is the region and the reason for the bleeding. If there is such, then you can switch for embolization technique. Involves, of course, small microcatheter 0.17 or less, and selectively go inside the vessels, reaching the area of interest, so can perform the embolization. A lot of different agents we have nowadays with which we can perform the embolization of the ruptured vessels. We can go from liquid embolic agents by geospon, histocrine, NBCA agents. Also, we can do application of selectively of coils. Everything like a foreign body which can cause this closure of the vessel. So I will show you several examples of epistaxis. This is a patient with refractory epistaxis in which we do angios without seeing any reason for the bleeding itself, no malformation, no pathological vessels, no aneurysms, or no other dilatation. So after he continuously developed this epistaxis without any macroscopic reason for it, after we do several selective angiography, we saw very rich network around the nasal cavity. And when the epistaxis continues more than 2 to 3 days, then we go for embolization. Here we go selectively inside distal internal maxillary artery and close it with particles so we can just reduce this network and we stop the bleeding which was refractory several days ago. This is another example with a patient with Wyburn-Mason syndrome on which we performed selectively DSA and we saw these small malformations which are like a small nidus of vessels cause this acute bleeding inside the nasal cavity. So our goal was to go selectively in, close as possible to the malformation so we can reach adequate level of occlusion of the last one so we can stop the bleeding. This is the selective catheterization going inside with microcatheter as close to the level of the malformation. We perform this proximal plug embolization by liquid embolic agent. And like you can see at the end of the procedure, there is no malformation left. You should remember about these syndromes, then you can observe additional AVMs intracranially, like in this case, asymptomatic AVM across the hypothalamic arteries feeding from the anterior cerebral arteries. Because it's asymptomatic, doesn't cause any blood or hemorrhagic complication, we just show that such kinds of syndromes can be recognized by this method. Sometimes when the patient has intranasal cavity tumors, they can cause itself the bleeding. If they're hypovascularity, there are a lot of vessels involved in the tumor, so they can cause this kind of bleedings. Like in this case, angiofibroma caused the epistaxis of the patient because of the rich vascular network of the tumor itself. Our goal, of course, if can reach selectively the tumor networks to embolize it at its maximal level so we can cause this ischemia inside the tumor and we can stop additional bleedings in the future. Like here with the balloon, to prevent our reflux, we go selectively inside and we fill as much as possible of the tumor vessels. Like at the end angiography, you can see like subtotal or almost total embolization of the tumor vessels. It's another case of angiofibroma with active epistaxis. Again, you can recognize very nice the rich area of the tumor blushing. So again, our role and our goal, can we go selectively enough to embolize only the tumor itself. Like here with the Apollo microcatheter, the Apollo is the detachable tip microcatheter. We go selectively inside. We were able to go selectively inside and to fill as much as possible the pathological network with liquid embolic agent. And in this case, we achieved total embolization of the tumor. This is the final angio with no signs of residual or still filling of the tumor itself. It was a very rare case in which our physicians from another hospital was asking for our help. They cannot recognize nothing inside the CT, nothing inside an MRI. So we performed the DSA on which our first investigation, we didn't saw any vascular reason for the epistaxis. But when we observed more and more the angio and we saw that it's active arterial bleeding inside the nasal cavity, we saw this small rupture aneurysm inside in the nose. So it was not easily recognized, but when you have this stagnation of contrast media inside and you see like an extravagation, you know this is the point of rupture. So again, we go selectively as possible, and by creating a plug and waiting patiently, we were managed to fill the aneurysm itself with liquid embolic agents. You can see it very nicely here. So it was completely stopped. At the final angio, we didn't observe any filling, and the bleeding stopped immediately at the point of the table. This is another interesting case for hereditary hemorrhagic teleanesthetizia patient with a lot of vascular, facial, and skin malformations, which can cause additional bleedings. You can observe here is with anterior and posterior nasal packing, because he has additional refractory bleeding from the nose itself and from the throat itself. So we do the angio, we saw a lot of pathological vessels, which were very rich area of almost like tumor blushing. So we decided we should embolize as much as possible so we can stop this active bleeding and give a chance for the physicians to do additional hemostops inside it. So we fill as much as possible with embolic agents, filling the whole tree of vessels, the distal penetration of the vessels, so we can prevent future bleeding. This is the final embolization with the whole internal maxillary artery filled, and it branches distally. This additional tumor, patient with a nasal tumor, so after the operation, they was not managed to stop the bleeding. So they refer the patient to us, we do angio, we still saw like vascular feeding of the tumor, and our goal was to stop as much as possible so they can deal with these hemorrhagic complications after the operation. We went selectively inside, we were patiently trying to fill as much as possible of the tumor. You see the network of the tumor filled with the embolic agents and total exclusion of the normal blood circulation at the end. This was iatrogenic ICA aneurysm, which was caused after transsphenoidal endoscopic surgery for macroadenoma or microadenoma patient. So after the procedure, they told us they cannot stop the bleeding after the surgery. So we do a DSA, we saw some small defect around the internal carotid artery wall, but at that time we were not sure if this was really the trauma they caused, coming transsphenoidally. The next day we do additional DSA, and we saw this pseudoaneurysm of the internal carotid artery, growth like several times just for 24 hours. So now we are sure this is the region and this is the cause of the bleeding. So we go selectively, do a small coiling because it's a very fragile lesion, the pseudoaneurysm. You cannot go for very compact density because you're risking to rupture it. It's a gentle, just created aneurysm. So we prefer to put a long soft coil and additionally braided stent so we can secure the bleeding. In summary, I try to show you as much as possible reasons for the nasal bleeding in epistaxis itself. It's very important to know that you have to deal every day or more often with this kind of pathology, not to cause additionally non-desirable complication. That's why I just show this statistic showed in the literature that when you perform epistaxis embolization, very, very rare, you can do additionally a lot of complication caused during the procedure. So have it in mind, just knowing good anatomy and have good enough experience to perform it every day or more often for lessening the percentage of complication which is occur after the procedure of itself. Embolization, unfortunately, is not very cost effective. Sometimes we can use different agent of embolization agent, and sometimes it's more expensive than the surgery itself, but it's less minimally invasive, it's less traumatic for the patient, and it's very fast to reach the region of interest and to embolize it compared to the surgery or direct ligation or direct coagulation, which can be also performed. Thank you for your attention.
Yeah, thank you for this overview, how to deal with epistaxis, especially when this subgroup of patients which cannot be managed by conservative treatment, about 7%, I think, yes?
Yes.
You need treatment.
It says
it's also my experience, yes. And the problem, you have pointed that out, is that we have not a nasal artery. You go in and then you solve all problems, but there are many, many branches supplying the septum, supplying then the lateral part of it, anterior, the posterior, and the facial artery naturally with its branches is important, but I have even found cases where branches from the ophthalmic artery went down So you have to go into the internal carotid artery, selectively place your microcatheter down over the ophthalmic artery down to do the embolization. That is very complex. So very impressive cases. Any questions? So you have convinced everybody and nobody has any question. Yes.
I'm glad.
Very clear what you presented.
Thank you.
So thank you again. And we proceed in the program.